is an autosomal dominant disorder characterized by the deficiency in hepatic, I'm repeating once again, hepatic urodecarboxylase. Deficiency in hepatic urodecarboxylase. And urodecarboxylase is the enzyme which is involved in the heme biosynthetic pathway, and it is responsible for the conversion of the uroporphyrinogen 3 to coproporphyrinogen 3. When the hepatic urodecarboxylase is defective, there will be accumulation of uroporphyrinogen 3, results in the deposition of excess porphyrins in the skin. Not only the uroporphyrinogen 3, one will also accumulate, like that coproporphyrin also will accumulate, like this. Porphyrins get accumulate in the skin, but typically uroporphyrinogen 3 as well as uroporphyrinogen 1. So excess porphyrin deposition in the skin, we know already that it is responsible for the formation of oxygen free radicals, which can damage cells, lead to photosensitivity. Same problem. So again, in the porphyria cutanea tarda, there will be a cutaneous photosensitivity as evidenced by fluid-filled vesicles and bullae over sun-exposed areas of face, the dorsum of hands and feet, forearms and legs. These are the areas. I am repeating once again, when we talk about the clinical manifestations, the patient exhibit cutaneous photosensitivity as evidenced by the fluid-filled vesicles and bullae over sun-exposed areas of face, the dorsum of hands and feet, forearms and legs. So often small white plaques like milia will precede vesicle formation. So this is called as milia, small white plaques, and other skin manifestations include hypertrichosis, hyperpigmentation and skin thickening. Remember, in the porphyria cutanea tarda, the name itself says that it is cutaneous in nature. There are no neurological manifestations in the porphyria cutanea tarda. And as I mentioned that all the porphyrins are accumulated and they are elevated and they are excreted in the urine. Lab findings are evident with elevated porphyrins and slightly elevated aminolevulinic acid. But remember one very important point in the porphyria cutanea tarda, PBG level is normal. PBG level is normal. Whenever you see the lab value PBG level is normal, then go and immediately mark that it is porphyria cutanea tarda. And there will be slightly elevated delta aminolevulinic acid levels, but chiefly elevation of uroporphyrinogen 1, uroporphyrinogen 3, coproporphyrin, all these elevated porphyrins in the plasma. PBG, porphobilinogen level is normal. That's the reason porphobilinogen, we said that it is a neurotoxic. Because it is normal, no neurological manifestations, and urinary ALA is slightly increased, that's it. So not significant enough to cause neurological or neuropsychiatric manifestations. That's the reason the patient exhibit mainly cutaneous photosensitivity, evidenced by the fluid-filled vesicles and the bullous formation over the skin exposed areas are typically seen in this case. Now, what is the treatment? Repeated phlebotomy is why we are performing, because it is a treatment of choice, mainly to reduce hepatic iron. Repeated phlebotomy to reduce hepatic iron, and low dose chloroquine, and stop use of alcohol, iron supplements, and all these, all of which can exacerbate symptoms. So this is what is the treatment, but generally examination point of view, what you need to remember is repeated phlebotomy is considered to be the treatment of choice because to reduce hepatic iron. And remember, homeless man is important, and you are also performing tests for the HIV as well as hepatitis. You order tests for that because remember the precipitating factors are HIV and hepatitis can precipitate symptom onset. The presence of any one of these can precipitate symptom onset. We don't know whether this patient has hepatitis B or not, or HIV is there or not, but as a note, HIV and hepatitis can precipitate symptom onset. is the Porphyria cutanea tarda.